So the first, I just have static images because I'm still learning how to use Visage. As a patient with history of rectal cancer, status pose APR, coming in with abdominal pain. So when I saw this case, I saw this nodule, and I'm like, oh, it's a peritoneal implant. The patient has no peritoneal implant. The patient had a prior PET-MR, and it was FDG avid. So I'm like, okay, done. Just more implant. But then on the resident report, it said like granuloma. I'm like, what? And then like I look into this further, and on the PET-MR, they said, the lesion has signal dropout on a post-face imaging. So this is the in-face imaging, and there's fat signal. And then on the post-face imaging, it drops out. So this, this one also had been stable for over a year. So this was a benign peritoneal nodule, and it's an encapsulated fat necrosis that I think if you weren't looking carefully could have been called a peritoneal met, because typically, fat necrosis, we think of having fat attenuation. This one doesn't have fat attenuation. This one looks more like central necrosis. So, I can see how like I or others would call this just a necrotic implant. But because it has signal dropout, that's what it is. So an encapsulated fat necrosis, here's an example from a radiographics paper, can mimic malignancy. So having in and post-face imaging is helpful, having, of course, comparison to priors and stability over time. Unlike regular fat necrosis, an encapsulated one has a fibrous capsule. And like you can see here, so there's this T2 dark fibrous capsule on this case from radiographics. And in my case, the signal drop out on a post-face imaging. But be careful, because it really has to do with the patient's history. So here is a mimic. So we have this fatty lesion. There's some soft tissue stranding. But this case from this radiographics paper turned out to be pathology-proven recurrent liposarcoma, which also has fat. So be careful. Not all lesions that are fatty look like fat on CT, and lesions that have fat in it may not necessarily be benign. They could be malignant. So that's my first case.
Cool. Anyone have any comments? I would say that I feel like fat necrosis is pretty common, and we need to recognize it in the post-operative setting, especially when they do like omental pedicles. So often like they'll take a piece of omentum and make a flap and kind of move it to another part of the body. If it's not fully vascularized, it can start necrosing and dying, and then you might get this kind of fat necrosis, or post-pancreatitis, or other kinds of surgery. And so one of the keys, I think that picture on the far left there is a really good example. It has like these thick kind of septa and rind to it, and it'll often involute over time. And it'll be FDG avid early on, and should become less and less over time. So you don't want to necessarily overcall it. That one, Nelly, doesn't look super FDG avid, so that might be, but like, of course, mental.
It's higher than normal background bowel, activity. So yeah, I don't think it's negative either.
Yeah,
but it's been around for over a year, so it's, I think it was hotter before.
Yeah, and it always gets smaller, never gets bigger. So
right.